Welcome to Morning Commute, expanding the use of oral maintenance therapy for acute myeloid leukemia among community-based clinicians. In this episode, Improving Survival with HMA Therapy in AML, Dr. Amer Zeidan and Dr. Guillermo Garcia-Manero discuss the latest clinical trial evidence for using hypomethylating agents as maintenance therapy for AML patients, as well as which patients will benefit most from these therapies. Morning Commute is developed by Projects and Knowledge powered by Kaplan and is part of a continuing medical education series. This CME CE activity is supported by an educational grant from Bristol Myers Squibb. Information about the faculty and disclosures can be found by visiting the URL in the episode notes or by visiting podcast.atpointofcare.com. You can use this link to receive your credit and evaluate this program. Dr. Zeidan is an associate professor of internal medicine, the medical director of hematology early therapeutics research, as well as the leader of the myeloid malignancies clinical research team and director of the hematology division at Yale Cancer Center, Yale University School of Medicine in New Haven, Connecticut. Dr. Garcia-Manero is a professor in the Department of Leukemia and director of the MDS AML Moonshot program at the University of Texas MD Anderson Cancer Center in Houston. I am your host, Candace Hoffman. Dr. Garcia-Manero will begin our discussion.
Dr. Zeidan, thank you for joining me today to talk about hypomethylating agents as maintenance therapy for our patients with acute myelogenous leukemia, or AML. Let's start with where we are right now with the treatment options and how we aim to lessen the chance of relapse.
So I think maintenance is a very interesting concept in management of acute myeloid leukemia. So just to kind of cover some of the basics, which I think most of our audience know, is that when you give intensive chemo, the induction treatment, which is very important in the management of acute myeloid leukemia, almost all patients would still relapse. We know that giving 1 or 2 courses of induction to patients with AML will not be sufficient for cure or for maintaining a long period of remission. And because of that, the concept of giving additional rounds of chemotherapy, which have different names in acute myeloid leukemia, we call them consolidation in AML. In ALL, they historically call them intensification, early intensification, late intensification, etc. And then there is a concept of maintenance, which generally is thought of as giving treatment to someone who is in remission, with the idea of giving a lower intensity treatment that generally can be given outpatient for a prolonged period of time. So that's the main difference from consolidation treatment, which is intense, sometimes giving in-house, sometimes requires transfusions and aggressive supportive care compared to what you do in a maintenance setting where the patient generally will not need transfusions, will not need to be admitted to the hospital. And of course, we have the transplant concept, which is still needed in many patients to ensure cure. I'm interested in your kind of thoughts about how this concept of additional therapy evolved in acute myeloid leukemia over the long years that you have been practicing, Guillermo.
Thank you, Amer. So this is true because if you have a little bit of historic perspective over, let's say, the last 20, 25 years, probably in the 90s, the main problem was to safely and successfully achieve a complete remission. And what I mean is, maybe in those days, we didn't have good antibiotic, antifungal, antiviral prophylaxis, etc. So induction was difficult, and probably there was a lot more mortality than what we see right now. And then over the years, as we improve supportive care, we improve induction modalities and so forth, we were very successful in terms of achieving a high rate of remissions. But the problem then became relapse. And as you mentioned very clearly, to avoid relapse after successful induction therapy, you have first to complete consolidation. That sometimes is difficult in itself, but it's really important. And then The final approach is, in some patients, transplant that is curative, but maybe limited to a little bit younger population and someone with a donor and so forth. So it's not something that we can do, unfortunately, with all patients, although should be the goal. So then we are left with a group of patients that achieve complete remission, completed the consolidation, that still are at risk of relapse because they are not undergoing transplantation. And now we are in the situation of the concept of maintenance therapy. That actually has been thought of for many years because transplant has improved a lot also over the last 20 years. So, maybe let's say in the 2000s, the threshold, the upper age limit was like in the 50s, and then we moved to 60s and 70s. But there was a period where, transplant was really reserved for relatively younger patients with this disease. And we always wanted to have an approach post-consolidation or maintenance that will allow us to control this disease. So this is basically the journey, in my opinion, and I agree with you, Amer, of a patient with AML.
So I think two big developments in my mind have taken shape in the idea of maintenance. So I think for a long time, maintenance has been actually a very important part in the management of several other acute leukemias, like acute lymphoblastic leukemia, which it was absolutely needed for improving outcomes initially in children, who are the vast majority of ALL patients, and then in adults, and then in APL as well, for a long time before we have ATRA and arsenic being used together. Maintenance was also a very important concept. So I think this has been always of interest in the management of acute myeloid leukemia, but for many years, until very recently, we did not have trials that conclusively shown an overall survival benefit. But I think the evolution over those years until we have that successful trial has been very interesting. And part of that is I think the idea of, are you trying to give like one therapy for all patients versus trying to give therapies based on individualized risk profile, what we call precision medicine. So there has been an interest in using drugs that are specifically targeted towards a patient-specific mutational profile, such as FLT3 inhibitors and IDH2 inhibitors, etc. We'll talk about some of those trials. But then the second, I think, important development is giving maintenance therapy both after the initial phase of chemo, which will be induction or induction plus consolidation, versus giving it after transplant. Because while we always say that many patients cannot be cured except with a bone marrow transplant, the fact on the ground is that despite transplant, many patients with acute myeloid leukemia still relapse. So I think the concept of maintenance in a post-transplant setting is still important, although there has not been yet a trial that conclusively showed post-transplant maintenance reduced the chance of dying from leukemia. So I think it's clear that maintenance should be strongly considered. We are going to cover in our discussion some of the, I think, important concepts in both post-maintenance, post-transplant and post-chemo, as well as some of the precision-guided medication, as well as the mutation agnostic, like oral azacitidine approaches.
Thank you, Amer. I think also what is very interesting is a little bit of historical perspective, because I think the audience, if it's, let's say, relatively young, may or may not remember actually that we did not have genomic or molecular information in our patients until actually kind of recently. Let's say maybe 10 years ago, we started like to really implementing this kind of next generation sequencing exams that we do in the bone marrow. So in the early 2000s, we will induce and we will go kind of blindly into these patients. And, of course, we had the cytogenetic data that is very important. And we knew that patient may be with poor, complex chromosomes, they did worse, but there was very little data. And then little by little, this genomic data came about. And then we started realizing that people with FLT3 mutations had a high rate of relapse when treated with conventional therapy. Then we learn about the IDH mutations that are very sensitive to particular type of drugs that were developed based on this finding. And then we found that these TP53 mutations actually, that probably in Dr. Zeidan's practice, my practice, are quite prevalent, were associated with these complex karyotypes and very poor outcomes. So all of a sudden, over the last, let's say, decade, I'm not sure if I'm correct there, but around that time, we realized actually that we could somehow anticipate or predict what was going to happen with our patients. And I think that has been really fundamental for our decisions in terms of what type of therapy to give, what type of consolidation, what is the risk of the transplant, should we really maintain a patient that is at very high risk of relapse post-transplantation.
There has not been, I think, a big focus on the clinical management guidelines for the use of maintenance therapy, except based on smaller data until the Quasar, which is the only large randomized clinical trial to show improvement of a maintenance drug, which is oral azacitidine, after intensive chemotherapy for management of acute myeloid leukemia. And therefore, this has not been heavily emphasized. But there were a number of recommendations, especially for FLT3 mutated acute, in which patients generally have a high risk of relapse. And we have been recommending bone marrow transplant for most of those patients, except those who do not have a donor or who are too sick or refuse it. And even on those patients, because of the high risk of relapse, FLT3 inhibition maintenance approaches with sorafenib, midostaurin, gilteritinib has been something that has been recommended to be considered in the guidelines. But outside of those approaches with oral AZA and FLT3 inhibitors, maintenance generally has not been recommended except on a case-by-case basis. Some people have used HMA-VEN, for example, for maintenance in patients who have high risk for relapse. But this is not yet supported by large data. And I think getting additional data will be very important to further give evidence for any additional maintenance approaches.
I agree with this, Amer. Also, I think the message is, when you see these patients, it's, FLT3 is one of the most common mutations, and it's going to dictate a very specific maintenance approach. And then you may have a small group of patients that are MRD negative with a good prognostic feature, let's say a core binding factor alteration, or maybe MPN1 mutation without FLT3 mutation that could be cured with a standard type of high-dose cytarabine approaches. But then the rest will benefit from an HMA type of maintenance approach. And as you mentioned, we're going to be discussing soon the Quasar study with oral azacitidine. That is the only phase 3 study that has shown improvement in survival on these patients.
So I think one of the important trials has been the RATIFY trial, which provided support for the use of midostaurin after intensive chemotherapy. So midostaurin is a dirty FLT3 inhibitor. It inhibits a number of other kinases as well. And the clinical trial that used midostaurin with 7+3, again 7+3 with placebo, showed a clear overall survival improvement with patients with FLT3 ITD or TKD. And in that trial, in the design of that trial, patients were allowed to continue on maintenance therapy for a year, 12 cycles of maintenance after the end of intensive chemo of induction and consolidation. However, there was no second randomization at the time of maintenance. Although this was part of the trial, there has not been a conclusive evidence about the benefit that you get with midostaurin. So there has been a controversy about whether to use it or not. I'm not sure what's your approach, Guillermo. Do you continue midostaurin in a patient who gets this kind of initial treatment?
I mean, to be clear, at MD Anderson, we've moved to maybe second, third generation FLT3 inhibitors that may or may not be approved for this particular indication. But we strongly believe that it's really critical to use these drugs as a maintenance type of approach, likely in combination also, maybe with an HMA, maybe with or without BCL2 inhibitor. But this was a very important study, Amer, because it was the first study really to show improvement in outcomes with patients with FLT3 mutated acute myelogenous leukemia. What about the impact of transplant actually in those patients?
Yeah, and as I mentioned, I think this is important in FLT3 positive disease because the guidelines continue to strongly suggest bone marrow transplant, at least with patients who have FLT3 ITD. there is a little bit more controversy about the TKD, tyrosine kinase domain mutation. So since many of those patients go to transplant and still a significant number of them would relapse, studies have historically included the use of a FLT3 inhibitor, for example, quizartinib in the Quantum First trial after the initial intensive chemotherapy. And again, there was no second randomization in this trial, similar to the Ratify trial. There was no second randomization post initiation of maintenance. So it's difficult to get specific conclusions, but it did seem that patients who have maintenance approach with the quizartinib seem to do better after those who did not receive quizartinib. So I think similar to what you have been noticing is that most institutions, I think, will still give some kind of a FLT3 maintenance after chemo if the patient cannot go to transplant or after transplant itself. But then the issue, I think, which became very important is the role of the MRD measurement. And this clearly, I think, has been put in the front by the Morpho trial, which looked at gilteritinib.
I think if we were going to summarize this, Amer, what we're talking about is, so we're kind of successful with induction. FLT3 mutations are important. You may be in a situation where patient may or may not be candidate for transplant, may or may not be candidate for particular FLT3 inhibitor, may or may not be an MRD. So that this decision-making is a little bit complex. But I think for the FLT3 mutated group of patients, it's kind of clear. But now we're going to be discussing those that actually don't have the FLT3 mutations and may not be candidates for transplant. Remember, actually, this is a disease of older people, actually. So a large fraction of these patients may not be transplant candidates. So let's discuss what do we do with this kind of, in a way, agnostic group of patients, Amer.
Yeah, so again, this is, I think, is a very important area because despite all of our efforts, many of those patients still relapsed after intensive chemotherapy. And there has been a number at different agents, including chemotherapies. And historically, because HMAs have been available for the management of MDS since the early 2000s, and they have been used in MDS and subsequently in AML, although they have not technically been approved for the management of AML for as single agents for a long time. And since the concept in lower intensity treatment patients, like patients who do not get intensive chemo, the approach has been to continue the HMA as long as the patient is responding. Some of those concepts were moved in a single arm studies and subsequently in randomized phase 2 and phase 3 studies to give patients injectable azacitidine or decitabine after intensive chemotherapy. And I think without going through details of many of those trials, there has been always a mixed evidence of benefit. Sometimes there's improvement in disease-free survival without improvement in overall survival. Sometimes the studies were underpowered. And those studies came from both Europe and the US. And actually one of the largest studies, which I think was in the post-transplant setting, came from your group, Guillermo, using injectable azacitidine after, I believe this is probably the largest randomized trial of HMA post-transplant. Not sure what your thoughts on that trial, which clinically was negative.
I think the issue, Amer, is that it was kind of logical, almost intuitive, right, to use these hypomethylating agents that first were developed in MDS and then later on in AML as an approach for maintenance therapy because they're well tolerated, the mortality is low, etc. But I think these studies, like the Hobon study, that ECOG study, maybe these MD Anderson studies, the issue is that in those days, because they're quite old, actually, some of them, we didn't know actually the molecular characteristics of these patients. So again, probably there was a little bit of heterogeneity in terms of who was actually enrolled in those studies, and they were not well controlled. And I actually think that's why there was a little bit of controversy around whether they were really positive or negative. I think most of us before what we're going to discuss now, the Quasar AML 001 trial, tended to use these HMAs one way or another post-consolidation. But the trials, I don't think, were well annotated until we got this phase 3 study that we're going to start discussing now. So let's discuss actually how we developed this drug, oral azacitidine. So here, Amer, if you allow me, because I had the opportunity to develop some of the studies, I will tell the audience how this was done. So from the beginning in myelodysplastic syndrome, because remember, azacitidine was actually the first hypomethylating agent approved for MDS, we were kind of plagued by this issue of the subcutaneous IV injections 5 to 7 days every month. So the reality is that patients were kind of complaining of the chronic administration, and the subcutaneous injection actually of azacitidine particularly can be associated with a little bit of chronic skin toxicity that maybe is not a big deal at the beginning, but then injection after injection, depending on the size of the patient, actually maybe a couple of injections per day, etc., really bother our patients. So from the beginning, we wanted to have an oral approach to this drug. And many years ago, actually, when there was a sponsor that was the one that brought the azacitidine to the United States, we started actually developing this concept of the oral azacitidine. So we did first a phase 0 trial here at MD Anderson, trying to see if by just administering oral azacitidine to patients with leukemia, we were able to see actually blood levels of the HMA in their blood. And actually, this paper that was reported in leukemia actually got 4 patients, and we were able to detect some kind of low levels of this drug. And then with that, actually, we moved into a phase 1 study, and that phase 1 study was eventually published in JCO. Took a long time, actually, because what we learned is that the area under the curve of oral azacitidine is significantly lower than what you see with IV or subcutaneous azacitidine. And but that actually had some positive aspects to this. So one could actually give this drug once, 2 or 3 times a day. You could do this for 7 days, 14 days, 21 days. So it allowed for a lot of kind of possibilities. So the phase 1 trial took a long time because we did all these kind of permutations of the dosing of the azacitidine. Why is this important is because from the beginning, when these HMAs were developed, we wanted to have perhaps a more chronic, long-lasting induction of DNA hypomethylation. And this all of a sudden was allowed by kind of the pharmacokinetic profile of this compound that, maybe low doses of, low absorption of this drug could actually allow for kind of chronic induction of this hypomethylation that may be a biomarker of how this drug works. So we were actually quite excited about this. And in addition, just to finish this part is, we noticed that despite the fact actually that the PK profile of the oral azacitidine was lower than that of IV subcutaneous azacitidine, actually there were significant responses with this compound in patients with MDS and AML. So all of a sudden we saw, well, maybe we don't need to give these IV subcutaneous concentrations and still have quite a bit of clinical benefit. And with that, actually, there were a number of phase 2, phase 3 studies that were developed, in particular this Quasar AML 001 trial that maybe, Amer, now you can tell us actually what it showed or what was the design, etc.
Yeah, so I think we'll spend a little bit of time discussing this trial because it's the only randomized big phase 3 trial to date that has shown improvement in overall survival in the maintenance setting of acute myeloid leukemia. And I think, Guillermo, you gave a very nice historical perspective on how this drug came about. So the drug basically was, or in the Quasar AML 001 trial, 472 patients, which in a large number of countries were randomized. Half of them received oral AZA and the other half received placebo. And you can see that when you think about the trial, those were patients who were receiving intensive chemo. They were older, but they were not going to transplant because they were older because they had complications from intensive chemo induction or consolidation, or because they did not want to. And when we think about the results of this clinical trial, the most important and the most notable clinical result is a significant, not only statistical significance, but also clinical significance of the overall survival that was observed with oral AZA compared to placebo, where the median overall survival was around 25 months compared to 15 months. So there was a median of around 10-month improvement in overall survival with a hazard ratio of 0.69 and a p-value of 0.0009. So very significant. And this clearly what led to the approval of this drug, which is currently available and is routinely prescribed according to the clinical guidelines.
If you allow me to interrupt here for a second, Amer, because I was part of those earlier studies, I'm very happy to see this data. But to me, actually, this is one of the most positive studies we ever had in acute myelogenous leukemia, actually. I mean, this is like 14 months versus basically you're gaining like 10 months of life in a very significant fashion. And I don't know if this study has resonated in the community as much as one will expect with this kind of data. But I think this is really positive, results actually.
Yeah, I agree with you, Guillermo. And I think, once you start dissecting the results a little bit, I think it's important to note that the benefit applies across different segments, which I think when the study was initially published, it wasn't very clear. For example, do the patients who, and maybe it's important here to recap the eligibility quickly as well, is that those were patients who did not complete their curative intent therapy. So the way it was defined in the protocol is that you could have gotten induction alone, you could have gotten induction plus 1, 2, or 3 cycles of high dose or intermediate dose cytarabine, but you would not have completed the entire planned induction and consolidation, and clearly you cannot go to transplant. So this is only post-chemotherapy, not post-transplant. And one of the important questions that came out is like, do patients benefit if they have received a significant chunk of their consolidation? Because we know that delivering additional chemo is important to reduce the relapse risk. And indeed, it's not only beneficial post-induction, although the p-value and the hazard ratio is probably better if the patient only got induction and no consolidation. But even if the patient has received any consolidation, whether they have received 1 or 2 cycles, they still had a statistically significant improvement in overall survival. And importantly, this benefit was also regardless of the MRD status, because, the argument is that maybe if the patient has still evidence of leukemia with MRD positivity, then giving additional treatment might help them more. And, again, there's even some debate about would you call this maintenance or do you call this preemptive therapy if someone is MRD positive? But the bottom line is that not only if the patient was MRD positive at screening, they benefited from oral AZA compared to placebo, but even patients who were MRD negative as well benefited from the treatment. So I think both of those are very important to emphasize. And the last point I would also make in terms of this subgroup analysis is that even patients who are older, so as we mentioned, the study included generally older than 55-year-old patients, but there were patients who were older than 75. And even among those patients, there was a significant improvement. You could even argue that the improvement was even better than younger patients, I suspect, because some of those patients cannot get, I think, a lot of the intensive treatment, the planned intensive treatment. But the overall survival was also significantly better with oral AZA compared to placebo. So I think in any way you have dissected it, by MRD, by number of consolidation, by the presence of MRD or not, and patients who have NPM1 mutations also have, I think, experienced very important benefit, where the median overall survival for those patients who are NPM1 positive with oral azacitidine was close to 4 years. So this is a significant survival for patients who are not going for bone marrow transplant. I'm not sure like if any of those results kind of resonated with you, Guillermo.
Yes, I was gonna politely interrupt, but I think one aspect of this Quasar study actually is exactly what you were saying in the patients that are older than 75 years of age. Because if you look at the overall survival, the hazard ratio is like 0.48. And actually their median survival is like close to 25 months for those treated with oral azacitidine versus like around 9 months for those on the placebo. I think these numbers are very, very strong. And actually, I think that's actually the huge unmet need, because I don't think anybody transplants any patient over 75 years of age today. Even at MD Anderson, probably nowhere. I mean, occasionally, very rarely. So this is the group of patients that really need this intervention. And this is actually incredible, right? It's almost like, doubling the potential for survival in these patients. So that's really, really important. I really also think that what you mentioned about the MRD is really powerful. And the fact actually that you may see this even in this group of patients with NPM1 mutation is really positive. So overall, actually, I think this data strongly suggests that this agent, oral azacitidine, post-consolidation therapy, or not, actually, as you were saying also earlier, is quite important in our patients, actually. So should be really the standard of care for those patients that are not transplanted.
An additional, I think, important point in patients with, in a subsequent longer-term follow-up from the trial, which was published in the American Journal of Hematology just last year, showed, I think, confirmed the results that those patients who, again, had intermediate or poor risk cytogenetics did benefit with an overall survival. Maybe we can also touch on the side effects with this drug and the management. And Guillermo, you have extensive experience having treated many patients with oral AZA. So what's your sense of the frequency of these side effects, and how do you go about managing them?
Yes, so thank you, Amer. First of all, for the audience, remember that this drug has a different dose schedule than traditional IV subcutaneous azacitidine, right? So we give 300 milligrams daily for 14 days. And the drug, actually, the positive thing is that the mortality rate through this treatment is actually extremely low, so it's very safe. But there may be some toxicities. Some of them are related to nausea and vomiting that are common, but most of the times very, very mild, and they can be really controlled with supportive care. Remember, this is a hypomethylating agent, so you will see, particularly through the first few cycles of therapy, some cytopenias. And basically, what you will do is after the first cycle of therapy and beyond, then you will start dose reducing to maybe from 300 to 200 for 14 days. If that's too much, then you can cut down to 7 days. But overall, this is well tolerated. This GI toxicity can be well controlled. And the cytopenias with subsequent cycles of therapy actually will lessen and will also be very well controlled. So I think this overall is not a difficult approach to deliver to our patients. So another question to you, Amer, is who should get this actually right now?
Yeah, so I think, in my opinion, anybody who meets the eligibility criteria of the trial, which is generally a patient who is older. And the reason why we say older, because those are the ones who generally will not go to transplant. So generally the treatment approach, at least in the US, is for patients who are adverse risk or intermediate risk is go to transplant, except if they can't because of toxicity or refusal or lack of donor. So someone who has some intermediate or poor risk, clearly not favorable core binding factor leukemia, and the patient is in remission after induction, and the patient generally will want to kind of, or compliant and is able to take an oral drug and doesn't have malabsorption. Ideally, someone who meets all of these criteria should be considered for this drug.
I agree. I think the main decision is whether the patient is a candidate for transplant or not, and then you make a decision. I think the other important issue, Amer, is Of course, this is not the end of the story. So now we have a nice backbone, if you will, with the oral azacitidine. And in general, the field in AML and hopefully also in MDS has been about combinations of the hypomethylating agent plus some other drugs. So I believe there are a number of active studies looking at potential combinations with venetoclax, with IDH inhibitors, with FLT3 inhibitors, etc., looking at this concept of maintenance therapy with oral azacitidine. So I think actually that likely we will see even better data than what we have reported from the QUASAR AML trial. I think the next question will be, we can discuss this briefly, Amer, if there is a role for maintenance post-transplant. Actually, I believe this is quite important, but maybe we can spend a few minutes discussing this.
Yeah, so I think this is also important. I think because of time, I just want to highlight a couple of points. One is there has not been a large randomized post-transplant maintenance trial that showed an improvement in overall survival. The closest we have gotten to so far is with the Morpho trial, which not on the primary analysis, but in an MRD-based pre-planned analysis that looked at patients who were MRD positive either before or after transplant, had an improvement with gilteritinib. So those were patients who had FLT3 positive disease. Outside of this specific area, most of the data has been relatively small studies or studies that have not been easily replicated. With sorafenib, for example, there has been an interest to study TP53 modulating agents. And of course, there are ongoing studies with venetoclax, AZA, and venetoclax, and even a big study with oral azacitidine. I'm not sure if you are involved in it, Guillermo, but clearly I think this is an area which is important and is going through a lot of research.
Yeah, I think what we're seeing is, some patients are cured with transplant, but many still relapse post-transplant. That's actually the key issue, particularly those patients with poor risk features that are transplanted, like P53, complex karyotype. And this is actually an incredible need. And I think, as you are saying, we don't have clear guidelines in terms of what to do. But I think in my practice, we use hypomethylating agent post-transplant all the time. As you mentioned, we actually did many years ago a phase 1 study of actually azacitidine in this context. You were part also of those studies with a drug called APR-246. The drug was never approved, but also trying to target this group of patients with P53 mutated disease, this issue of whether you give donor lymphocyte infusions or not early in these patients at very high risk for relapse. But that's also a major unmet need for those patients that are transplanted, where you can basically anticipate that there's going to be a potential for transplant, mainly those P53 mutated patients. I think there's been some approaches with HDAC inhibitors, with some of investigational drugs, but right now the best approach will be a hypomethylating agent. I think an oral drug will be ideal. If you had actually FLT3 or IDH mutation, you could also consider that. So I think maybe to wrap this, we could start talking about, maybe, some of these kind of latest clinical trials looking at HMA maintenance therapy. If you want to, approach this, Amer.
Yeah, so I think two studies that I'm particularly looking to see the results of, hopefully in the next couple of years. One is the Amadeus trial, which is actually similar to the QUASAR trial, is looking at oral AZA maintenance after undergoing transplant. And this is a large international trial that I believe has completed accrual, and we are waiting for the results for. And then the other one is Viality, which uses venetoclax, which is approved in the management of older unfit patients in AML in combination with AZA post-transplant. This is also a large randomized phase 3 trial. So I think both of those trials have the potential of changing the management of post-transplant management of patients with AML.
Thank you, Amer. So before you give us the final key takeaways, if we can summarize. So I think most patients will be candidates for induction. Most patients may be candidates for consolidation. The question is how many cycles of that consolidation therapy will they be able to receive? You're going to be looking at particular mutations, probably most relevant FLT3 mutation, because there are drugs that have shown to improve also survival of these patients, then you're going to make decision whether you're a candidate for transplant or not. And what I think the last part of this conversation became very interesting is in those patients that are not transplant candidates, this Quasar AML 001 study is the first and only study so far to, in a phase 3 design, showed a very significant improvement in survival, particularly for older patients, regardless of how much consolidation and their MRD status or even the NPM1 status. But the last part of the conversation post-transplant is also quite important. It's like maybe in younger patients that go through transplant with high rate of relapse post-transplant that can be actually predicted because maybe P53 mutations. The use of these compounds is being investigated and is something that many of us actually do right now. And perhaps you want to close with the final message, Amer?
Yeah, so I think, as you mentioned, it's very important to consider maintenance options in patients. And the field is moving very quickly, and we currently have good options to help our patients post-chemotherapy, intensive chemotherapy, and hopefully soon post-transplant as well.
Thank you. And maybe I'll do one more final summary. That is, again, oral azacitidine is the first approved maintenance therapy for AML for those patients in remission after intensive chemotherapy, not undergoing stem cell transplant. Please remember, actually, that these are not the same drug. As I mentioned at the beginning, the pharmacokinetic profile is quite different. So the IV azacitidine is a very different drug than oral azacitidine. Remember, this is given orally for 14 days. We discussed the FLT3 inhibitors, and again, we discussed that transplant therapy should be also strongly considered, but that may be also a need for maintenance therapy post-transplant in some of these patients. And with that, I want to thank you, Amer, for this opportunity and for spending some time discussing this very important topic. Thank you.
Thank you so much.
Remember, to receive your credit and evaluate this program, please visit the URL in the episode notes, or by visiting podcast.atpointofcare.com. You can find all the episodes in this series and all of our other podcasts on your favorite podcast streaming service, or download our Morning Commute app. Thank you for joining us today.